Hi everyone. Today we will have a short presentation about the rehabilitation following peripheral nerve reconstruction. Before going to the rehabilitation part, we will see the basics of surgical procedure following nerve injury. Based on the timing, the surgical nerve repair classified into primary nerve repair, secondary nerve repair. Primary nerve repair indicated for clean, sharply cut nerves performed immediately after an injury or within 1 to 2 weeks. Secondary nerve repair usually indicated in the presence of severely crushed avulsed nerve or multi-level lesions. Yearly secondary repairs are performed within 6 weeks and late secondary repairs after 3 months. The different kinds of operations performed to repair the nerves. Neurolysis. It can be divided into internal or external. Nerve repair, end-to-end nerve repair, autologous graft, neurotization, muscle and tendon transfer. Neurolysis. It is a process of release of nerve sheath by cutting it longitudinally. It is internal neurolysis. And operative breaking up of perineural adhesions. It is called external neurolysis. Relief of tension upon a nerve obtained by stretching, destruction or dissolution of nerve tissue. Epineural repair. It is for a completely transected nerve. Cut nerve and debraided and serially sectioned until the exoplasmic outflow mushrooms under positive intrafascicular pressure and fascicular pattern is identified and relatively free of scar. 8 to 10 sutures for a large nerve and 2 for small one. Leading cause of failure is gapping, overriding, buckling, straddling of fascicle ends. Fascicular repair. It is a perineural repair. Nerve ends prepared and epineurium is dissected away. Fascicles are separated and coaptation is performed between matching fascicles with sutures placed into the inner epineurium and not to enter in the endoneurium. Advantage is accurate coaptation of similar size fascicles. Disadvantage is stimulation of greater amount of intraneural scar by increased resection and foreign materials. Nerve graft. When continuity defects are present in the injured nerve or created in preparation of the nerve for repair, graft may be indicated. Alternates to nerve graftings are nerve lengthening techniques or bridged by tubes of biological or non-biologic material. Example is polyglycolic acid, autogenous vein, and amnion. Tendon transfers. Application of motor power of one muscle to another weaker or paralyzed muscle by transfer of its tendinous junction. Donor must be strengthened postoperatively. Following a post-surgical nerve repair, we'll do the following evaluation before starting the physiotherapy care. Detailed history of the injury. This includes nature of injury, level of injury, date of injury or repair, patient's problems, evaluation of sympathetic function, manual muscle test, aware of the limitation in passive range of motion due to muscle shortening or contractures, trick motions, rebound, supplementary action, antagonist, common tendons. Range of motion, sensibility examination. An initial latent period of 3 to 4 weeks, axonal regeneration progresses at a rate of approximately 1 millimeter per day. Sensibility occur in following sequence: deep pressure and pinprick, moving touch, static, light touch. At first, a stimulus will be poorly localized and may radiate proximally or distally. Accurate localization is among the last sensibility functions to recover. Typical tests are Tinel sign and Siemens-Weinstein monofilament test. Then pain assessment. The common cause of pain following nerve repair is causalgia and neuroma. Analysis of the impact of the injury on the patient's functional status. The physiotherapy treatment goals are maintain range of motion, maintain nerve integrity, increase muscle length, increase sensation, manage neuropathic pain. To prevent stretch of the sutured nerve end, a plaster slab is applied after the operation and worn for 2 to 3 weeks with adjacent joint positioning to reduce tension. No passive stretch of the nerve is allowed for 8 weeks. The limb is supported initially in elevation to prevent edema, and exercises are given to maintain the range of any free joint during this period of immobilization. For example, a lumbrical bar splint in case of ulnar nerve injury that keeps the metacarpophalangeal joint in flexion and interphalangeal joint in extension. Dynamic splint for ulnar nerve injury. There is another picture showing short arm opponents for median nerve injury. This is a long arm splint for more proximal radial nerve injury. The first 1 to 3 weeks, the limb must be supported comfortably in elevation. Active movements of the unaffected joint of the limb are encouraged. Pulsed electromagnetic energy should be given daily through the dressing to the affected part. 3 to 5 weeks, free active movements are encouraged in order to retain range. Passive physiological movement must be given in the absence of normal voluntary movement. Electrical stimulation for proprioceptive feedback of recovering muscles. Position hold exercise, avoid putting tension on nerves ends at this stage. 6 to 8 weeks, deeper massage is given to help free adhesion, scar, and soften indurated areas. It is safe in this stage to introduce graduated resistance to all movement, which will help to free adherence and mobilize any residual stiffness of joints. Pain is usually decreased by the use of TENS. Splint can be used in night only. 8 week onwards, more vigorous resisted exercises are now introduced. Passive stretching is required if full mobility of the soft tissue has not been gained. Serial stretch plaster are necessary in stubborn cases. Special care must be taken to assess the patient's suitability to a splint and desensitization. Training task, localization of stimulus, identification of sandpaper on towels, identification of textures, identification of Velcro letters on wood, ADL with vision occlusion is given. Thank you.